Hello everybody, Dr. Alex Vasquez here with today's video, which is going to focus on reviewing JAMA Cardiology's 2018 article, Omega-3 Fatty Acid Supplement Use with Cardiovascular Disease Risks. Let's begin by taking a look at that recently published article right here. Again, this was published in JAMA Cardiology, January 31st, 2018. That's only about 2 weeks ago, and the article has already had more than 100,000 views. Typically, when JAMA is going to publish an article against nutrition, they make the article available online and free, and that's certainly the case here. Again, title of this article, Associations of Omega-3 Fatty Acid Supplement Use with Cardiovascular Disease Risks, subtitled Meta-Analysis of 10 Trials Involving 77,000 Individuals, almost 78,000 individuals. In order to put this article in context, I'm going to start by contextualizing the organization and the journal itself. I'll try to keep that relatively short so we can dive into the analysis of this article, but I do think that some contextualization is important because this journal is considered to be very authoritative. It's used by news services. A lot of press releases certainly went out about this article, showing and stating basically that fatty acid supplementation from fish oil is of no use in the prevention of cardiovascular events. So let's put that in context. And in order to do that, I'm going to start by taking a look at the journal. Journal of the American Medical Association, JAMA, is notorious for publishing pro-drug and anti-nutrition articles. Big medical journals and organizations make multi-million-dollar profits from their pro-drug stance, and they have a massive inherent conflict of interest to publish pro-drug articles and anti-nutrition articles. One of the ways that this conflict of interest manifests is that drug companies will often buy a pro-drug article or an anti-nutrition article, and they'll often pay millions of dollars for those reprints. You can see that that was detailed here in an article by Richard Smith, former editor of the British Medical Journal. Medical journals, he states, are an extension of the marketing arm of pharmaceutical companies. This article was published in PLOS Medicine in May of 2005. You can get that online. These medical journals and organizations also publish pro-drug advertisements. That's another source of several $million in profits. They also endorse pro-drug treatment protocols, and that, of course, benefits the drug companies, and the drug companies then reciprocate by promoting pro-drug, pro-medical legislation, and that's how we end up with mandatory drug and vaccine protocols. So you can see that all of this becomes a pro-drug vicious cycle. I actually have personal experience with JAMA, again, which I'm stating here is notorious for publishing pro-drug and anti-nutrition articles. This article that I'm going to talk about very quickly was published in July of 2004. Effective soy protein containing isoflavones on cognitive function, bone mineral density, and plasma lipids in postmenopausal women. Now, just looking at the title of that article, which of course was also made available for free because JAMA likes to slam nutritional interventions. So pretty much from the moment that I looked at the title of this article, I already knew that it was going to be a study designed to fail. If you look at the title, Effective Soy Protein Containing Isoflavones on Cognitive Function, Bone Mineral Density, and Plasma Lipids in Postmenopausal Women, those are a lot of different variables, each of which, of course, requires different measurement and statistical analysis, etc. And probably they're not going to let soy protein with isoflavones actually win the day because this is a multi-million-dollar market. And I'm not talking about selling soy protein. I'm talking about the drug market for each one of these clinical entities. Cognitive dysfunction, osteoporosis, and dyslipidemia, those are multi-million and probably multi-billion-dollar markets. JAMA certainly is not going to publish an article favorable to nutrition, and that's what I suspected, and that turned out to be the case. In fact, this article was so bad that I actually published a reply, and they were, in one sense, they were kind enough to publish my work. On the other hand, they pretty much destroyed the intention of what I had written. So again, I thought this article was rather ridiculous, so I wrote a reply. They decided to publish it. However, they completely edited out any significant meaning from my letter. They reduced the word count by about 60%, and they took out what I consider to be the most significant part of my reply. And then I ended up getting this publication of only about 4 sentences in JAMA instead of the other major paragraphs that actually contained what I considered to be the meat of the matter. Then the original authors were allowed to retrofit some data which hadn't been published previously and which they then claimed maintain the validity of their research. And I have to say that I don't agree with that. If it had been valid from the start, they should have published that data from the start, not retrofit their data in reply to my truncated critique. So as a result of all this, basically the science was obscured, and it was done so for the purpose of maintaining pharmaceutical dominance, in my opinion. Let's get back to this article and take a look at it through kind of a structured analysis, we might say. You've got the citation, you've got the design. It's a meta-analysis of 10 trials with almost 78,000 people. Findings: randomization to omega-3 fatty acid supplementation, eicosapentaenoic acid, with a dosage range of about 200 to 1800 milligrams, has no significant associations with coronary heart disease death, although it did reduce the rate ratio, or the relative risk, by 7 percentage points, non-fatal myocardial infarction reduced by 3 percentage points, or any coronary heart disease events, 4% reduction there. Their conclusion: supplementation with marine-derived, so that's fish oil, marine-derived omega-3 fatty acids for a mean of 4.4 years had no significant association with reductions in fatal or non-fatal coronary heart disease or any major vascular events. So basically they're saying that fish oil does not function or does not provide benefit to reduce cardiac morbidity and mortality. So that's basically their conclusion, and that's what got picked up in the news. So now let's begin to look at the errors in this publication. Number one, error by unjustified selective exclusion of data. Again, error number one that I've listed here is unjustified selective exclusion of data. The authors state, this meta-analysis included randomized trials that involved at least 500 participants and a treatment duration of at least 1 year. Well, if they're going to exclude a lot of data, they need to justify why they're doing that, not just say, hey, we decided not to look at all this data. No scientific justification for this selection exists, and therefore its inclusion must be questioned. So again, one of their selection criteria was that all the studies that they were going to analyze had to have at least 500 participants. And my question is, well, where'd they come up with that number? Like, there's no justification for that. So they were obviously very selectively excluding a bunch of data that they didn't want to look at. My question is, why were the smaller studies, arguably easier to manage and perhaps with higher quality supplements, why were those excluded from this analysis? And I've also included a little more commentary at the bottom of the page. You can pause the video at any time if you want to read everything word for word. I'm going to try to maintain a little bit of momentum here. Error number two that I'd like to talk about is inclusion of studies that employed non-therapeutic dosing. The authors state, no minimum daily dosage of EPA or DHA was specified. Now, you should be raising your eyebrows at this point, and you should be asking yourself, what's going on here? They had no minimum dose of the active components of the intervention that they're trying to analyze here? That's completely ridiculous. So, like I've stated previously with regard to vitamin D, subphysiologic dosing is subtherapeutic. A lot of times in these nutritional studies, they use low doses, sometimes subtherapeutic and subphysiologic doses, which obviously are not going to work in order to provide the desired outcome. We have to use therapeutic doses of drugs, we have to use therapeutic doses of nutrients if we want to see the outcome effected. So one of the ways that nutrition articles get shortchanged is the investigators use low doses or they use insufficient duration of the study so that the nutritional studies are shown to be inefficacious, and that's exactly what they did here. In this case, by stating no minimum daily dose of EPA or DHA was specified, basically what they're saying is they had no standards for evaluating the appropriateness of the intervention, and therefore, of course, some studies will be published and analyzed within this meta-analysis showing inefficacy of the intervention when in fact it was a study design error, not an intervention shortcoming. So stated more plainly here, this article published in JAMA Cardiology is absurd for not emphasizing and including a minimum dose for the treatment being analyzed. By comparison, no meta-analysis of a drug treatment would be published if the authors ignored dosing or used homeopathic dosing levels, because everyone knows in pharmacology and in medicine and in nutrition that we expect to see a dose-response relationship, and that this is, of course, of huge importance. Therefore, to exclude this basic tenet of pharmacology, the dose-response relationship, is another big red flag that this review article is deviating from basic norms of science. And you can see I excerpted a clip from the article itself. No minimum daily dose of EPA or DHA was specified. So that's a huge red flag that this is basically a nutrition witch hunt, and they're trying to look for data that makes fish oil supplementation look non-efficacious for the prevention of cardiovascular events. Let's continue this analysis. So here we're going to start looking at each of the individual studies that were analyzed in this so-called meta-analysis. Again, not only published by JAMA, but published by the subspecialty journal JAMA Cardiology. So let's see what we find from this table. Number one, the majority of studies reviewed in this meta-analysis used inadequate subtherapeutic dosing, which in my opinion should be a minimum of 1,800 milligrams of EPA and DHA. Most of the subjects in these studies were not young, healthy patients. These were already patients of older age, a lot of times with metabolic syndrome, obesity, and cardiovascular disease. So what is not appropriate is to use a preventive nutrition dose for something that requires therapeutic intervention. Lower doses of nutrients can be used for prevention, but for actual treatment, which applies to most of the subjects in these studies, for actual treatment, they needed higher doses for a variety of reasons. They've got inflammation, they've got insulin resistance, a lot of them were obese, so they're going to need higher doses than what we would use in younger, healthy patients for disease prevention. So again, I think, and I'll show you the justification for this in just a moment, the minimum dose here should be 1,800 milligrams of combined EPA and DHA, not one or the other, EPA and DHA together. If you look at the ingredients that were given to the subjects, you'll see that most of the studies didn't meet this minimal criteria of 1,800 milligrams per day of EPA and DHA. You can see that this study was inadequately dosed. You can see that this study was inadequately dosed. The following study reached 1,800 milligrams, but they had no content of DHA, docosahexaenoic acid, which is the omega-3 fatty acid most important for changing the omega-3 index, which I'll talk about in just a moment, and also most anti-inflammatory for the cardiovascular system, which is basically how this is viewed these days. A lot of articles have stated that DHA is not simply important for the retina and the brain, but also it's the most important of these fatty acids for its cardioprotective benefits. In this particular study, the third one that we're looking at here, they used 1,800 milligrams of EPA, but they had no DHA, so that's basically saying that they excluded what a lot of specialists would consider to be the most important component. Also, this particular study was performed with subjects exclusively from Japan, where they have a higher intake of omega-3 fatty acids. Therefore, we could argue very reasonably and very easily that those patients would need higher interventional doses compared to those used in societies, for example, in the United States, where people don't consume enough omega-3 fatty acids. If the baseline intake of omega-3 fatty acids is higher, then the interventional dose also needs to be higher. Whereas, again, if you're looking at subjects from the United States who typically don't consume omega-3 fatty acids in their diet, then a lower dose is actually going to have a better effect in those patients because they're starting from such a profound deficiency. Here again, you see that this study used absolutely inadequate dosing. 226 milligrams of EPA along with 150 milligrams of DHA, that's absolutely, I would say, infantile. That's an appropriate dose for an infant, certainly not for an adult. Again, with this article, barely more than 1,000 milligrams, certainly not 1,800 milligrams of EPA combined with DHA. This one got to 1 gram, and this one also was barely over 1,000 milligrams. So of the studies that were analyzed in this supposed meta-analysis, of the 10 studies that they analyzed, only 3 of them actually had what we would consider therapeutic dosages of the intervention that's being assessed here. So again, right from the start, we can see that this article is probably going to be a witch hunt trying to find data that makes fish oil look inefficacious for the prevention of cardiovascular events. Only 3 of the 10 studies actually meet criteria for being reasonable studies in terms of therapeutic dosages. And as I state here, the anti-nutrition bias of this publication is obvious because the authors and editors would never publish a review article using inadequate dosing of medication. So for example, let's say that the therapeutic dose of a drug is 10 units and several studies are performed using only 3 units of that drug, whether it's milligrams or grams or whatever. So if they only use 30% of the effective dose, What's the point in analyzing those studies? They're underpowered therapeutically. So you can be sure that any meta-analysis that looks at several studies, each of which is therapeutically underpowered, is going to reach the conclusion that the therapy doesn't work. They do that all the time with nutrition studies, but they would never do that with a drug study. They would never say, the therapeutic dose of this drug is 10 units, we're only going to give 3, and then we're going to collect all those studies that were underpowered therapeutically, and we're going to do a meta-analysis. And lo and behold, our conclusion is that this drug doesn't work. They would never do that with a drug. They do it all the time with nutritional interventions. As I had stated previously, furthermore, most of these patients are post-myocardial infarction. They've got systemic inflammation and or they are obese, and therefore they need higher interventional, not preventive doses. Again, only 3 of the 10 studies in this meta-analysis are appropriately therapeutically powered. So let's continue the analysis. I'm going to stay with this major point that one of their errors was the inclusion of studies that employed non-therapeutic dosing. Let's look at this article for some context. This article was published in the well-respected specialty journal Prostaglandins, Leukotrienes, and Essential Fatty Acids. This was published in 2017. Supplementation with high-dose docosahexaenoic acid increases the omega-3 index more than high-dose eicosapentaenoic acid. So this is comparing DHA against EPA and the effect that either one of those will have on what's called the omega-3 index, which is a measure of omega-3 fatty acids in cell membranes. The omega-3 index correlates very strongly with cardiovascular disease and coronary mortality. So typically, what's considered good is to have an omega-3 index of about 10%, somewhere between 8% and 12%. But let's just say 10% because obviously that's in the middle. So our goal for preventive purposes is to have an omega-3 index of approximately 10%. So that means that of the fatty acids analyzed, roughly 10% of those are EPA and DHA. So then the question becomes, well, do you want to use EPA, DHA, or a combination of the two? And what this article shows is that DHA is more potent in increasing the omega-3 index than is EPA. So in order to summarize and clarify, let's take a look at this excerpt from the article. A high omega-3 index, which reflects a relatively high content of EPA and DHA in membranes of red blood cells, has been associated with lower risk of coronary heart disease and mortality in observational studies. Emerging evidence suggests that DHA may be more potent than EPA in modifying cardiometabolic risk. And they conclude toward the bottom, the increase in the omega-3 index is significantly greater after supplementation with high-dose DHA at 2.7 grams per day than with a comparable dose of EPA. So DHA is more potent than EPA in increasing the omega-3 index, and a good amount of research suggests, if not shows, that DHA is more cardioprotective. So now let's go back to the analysis of this article and look at the DHA content of the supplements that were used. Again, you'll see that the doses were at sometimes 0 and other times quite low. 200, 350 milligrams, 150 milligrams, that's not much at all. 380 milligrams and 375 milligrams. So at no point in time were the majority of these studies that were included in this meta-analysis actually capable of providing a good therapeutic outcome. When you look at the DHA content, you see that throughout most of these studies, the content was too low and therefore was not going to be adequate for providing cardioprotection. So before we leave this page, I'll make a few more points which are kind of tabulated here. The 2 most common strategies for unscientific sabotage of nutritional studies are 1, insufficient dosing, and 2, insufficient duration. You can see that I've talked about this with regard to vitamin D studies in an article that you can get online at ichnfm.org/D. Nutritional interventions, especially fatty acid supplementation, function via changes in structure and function, in this case changing cell membranes and gene expression, not, as with drugs, the instantaneous blocking of enzymes and receptors. Therefore, not surprisingly, for fatty acids to exchange in cell membranes and reach a new steady state, a minimum of 5 months of treatment is required. Furthermore, nothing justifies the constant use of the lowest imaginable dose. If you look at these studies, not only were they underpowered therapeutically, but It's the lowest possible dose that they could get away with, basically, and still call it a study. And I think that that's really a disservice, not simply to the entire medical community that's trying to understand this, and not simply to science itself, and not simply to the patients, but it's really just wasting time, basically, when these articles use subtherapeutic doses of nutrients as if they're searching for the conclusion to show that the nutrients didn't work for whatever the desired outcome might have been. So basically, everybody gets shortchanged when these articles are underpowered, either in terms of dosing or duration or other context. Speaking of context, let's take a look at this article from the Journal of the American Heart Association. This was published in 2013. Remember, this article that we're analyzing here from JAMA Cardiology was published in early 2018, so they had at least 4, if not 5 years to take advantage of the research that was published here, and certainly not in an obscure journal. This is Journal of the American Heart Association. And you'll see again what's being discussed here is the omega-3 index, which is the sum of EPA and DHA content in red blood cell membranes. This is a biomarker of omega-3 fatty acid status, highly correlated with myocardial EPA and DHA content. So basically what was just stated there is that by looking at this omega-3 index, by looking at the fatty acids in red blood cell membranes, you're actually taking basically a virtual biopsy of the heart to see what fatty acids are constituting that heart tissue. They go on to state an omega-3 index of equal to or greater than 8%, remember what I had said earlier, I recommend 10%, has been recommended as a cardioprotective level on the basis of associations with reduced risk of primary cardiac arrest, sudden cardiac death, coronary atherosclerosis, and acute coronary syndrome. In studies of Americans not taking omega-3 fatty acid supplements, the mean omega-3 index values range from 4% to 5%. And again, we want 10%, which is only achieved through frequent consumption of fatty fish or the use of fatty acid supplements. And again, this was published in the Journal of the American Heart Association in 2013. We're using this to critique an article published in 2018. How is it that these authors, publishing in JAMA Cardiology, remained selectively ignorant of this very important publication? Let's look at an excerpt from this article. Participants taking 900 milligrams per day achieved a median omega-3 index of 7.6%, so that's a little bit low, whereas the 1800 milligram per day group achieved a median omega-3 index of 9.9, or almost 10%, which is exactly what I had stated previously. So based on this, I think we're justified in stating that 1800 milligrams is the appropriate therapeutic dose to achieve the desired omega-3 index, which we want to see at approximately 10%, certainly more than 8%. And again, we achieve that by a dose of approximately 1800 milligrams per day of EPA and DHA. Now, let's look at which of these studies provided that minimal therapeutic amount. Certainly this one did not. This one also gets excluded. This one didn't provide any DHA at all, so it's of course excluded. The following study was also inadequately dosed, so same with the following, and this one. So again, we're left with only 3 articles out of the 10 that reasonably represent what we might consider to be an appropriate intervention, or as we might say, the current state of the art. So the question that I started to ask when I was looking at this article is, how on earth can a meta-analysis on omega-3 fatty acids and cardiovascular disease get published in a cardiology specialty journal in 2018 without any mention whatsoever of the omega-3 index? My conclusion to my own rhetorical question is that this is the intentional creation and propagation of nutritional ignorance, not simply among the population, but specifically among the population of medical physicians who don't receive nutritional training in their years of medical school. And now we're simply perpetuating their ignorance by giving them an article like this one published in JAMA Cardiology, which misrepresents the science. In addition to low dosing, some people would probably argue that because most of these studies used in a natural or kind of semi-synthetic form of fatty acid supplementation, that's also a disadvantage to the majority of the studies that were included in this meta-analysis. 9 of the 10 studies used in this meta-analysis used kind of synthetic or semi-synthetic, the ester form of omega-3 fatty acids. This is in contrast to the natural and arguably easier to digest triglyceride form. And you can see that that was stated in this excerpt. Combinations of polyunsaturated fatty acid ethyl esters of EPA and DHA were used in all but one trial, and that one trial used EPA without any DHA, so it was obviously hindered in its ability to produce the desired outcome. The daily doses, just to review again, the daily doses of EPA varied from 226 milligrams to 1800 milligrams per day, and the DHA content varied from 0 to 1700 milligrams per day. Well, obviously 0 would be subtherapeutically dosed because that's basically providing 0 content of what's now considered to be the most important, the more important of the two fatty acids between EPA and DHA. Again, these days, many would argue that DHA is at least as important as EPA, so the inclusion of studies that have 0 or insufficient content of the active component is pretty much ridiculous. Again, no meta-analysis and probably no primary research article that underdosed a medication would get published in a big mainstream headlining journal. The editors would reject it and they would say, well, of course your study didn't work out because you only provided 30% of the dose. But here, when they do that with nutrition, they publish it, it gets 100,000 reads in 2 weeks, and it makes the headlines in probably every newspaper. Critique number 4 that I have of this article is stated conclusion at odds with the data. So they say that they found no significant associations when in fact the associations that they did find were all favorable toward fish oil. So you can see here in this table they're showing the information that either favors treatment or favors control. If we're on this side of the line, then that favors treatment. Over here favors no treatment. So the data that supports the use of fish oil is basically summarized by these images here. You can see the bigger boxes represent more data and more patients. The smaller boxes indicate a smaller amount of information. If you just look at the graph, you'll see that most of the data favors treatment. The boxes are bigger and we have more boxes on this side. So 6 out of 10 of the studies actually favor fish oil supplementation. And also, not only do we have more studies, but we also have larger populations of subjects represented by that data. So not only do we see more studies supporting this view, but we also see larger groups of patients benefiting than not benefiting from fish oil supplementation. So this was figure 1 from the article. Let's take a look at another figure here. We're going to look at figure number 3. Again, you see most of the outcomes favor treatment with fish oil. You see more boxes on this side than you do on this side. And again here from their figure 4, we see more data points and larger data points on this side. All of these favor fish oil supplementation, basically. Associations with omega-3 fatty acids, fatal and non-fatal vascular events by trial design. Again, all of these, or what appears to be virtually all of these, favor treatment with fish oil supplementation, yet the authors published the conclusion that omega-3 fatty acids were not beneficial for the prevention of cardiovascular disease and death. Critique number 5 that I have for this article is simply that most of the authors had affiliations with medical schools, which are brutally pro-pharma and anti-nutrition, and that several of the authors were paid directly by drug companies that sell drugs of interest to the prevention of cardiovascular disease. Nearly all medical schools and organizations are rabidly pro-pharm and pro-chem, lovingly accepting money from drug and chemical companies and promoting faculty that are pro-drug and anti-nutrition. And I suspect that that's what we're looking at here in their author affiliations and conflicts of interest. So finally, to summarize my critique of this article, problems with this publication: unjustified selective exclusion of data, inclusion of studies that employed subtherapeutic or non-therapeutic dosing. This article really took underdosing to the extreme and completely ignored a foundationally important advance in cardiology and biomedical science, and that is the omega-3 index. 9 of the 10 studies used in this meta-analysis used a synthetic ester form of omega-3 fatty acids. This is in contrast to what many would prefer, the natural, easier to digest triglyceride form. Their stated conclusion that omega-3 fatty acids are not efficacious for the prevention of cardiovascular disease and death is at odds with the data that they presented, and I think the pro-pharma conflicts of interest among the authors and the publishing organization are also worthy of comment. So thank you very much for your attention during this brief analysis of this article, and I look forward to sharing more nutrition information with you in the very near future.